When choosing an abdominal CT protocol, there are a few important things to consider. For every study, think what field of view do I want? Do we need contrast and what type? What would be the best contrast timing? And overall, how can we best answer the clinical question, putting everything together? Here's some of the commonly ordered protocols that I'll go through today. First is the abdomen and pelvis with contrast. This is probably the most commonly ordered study you'll see. This is done during a portal venous phase of contrast. So here's a diagram on the left showing the different phases of contrast that we have. So after injecting, we can wait a certain amount of time. And in this case, we're waiting 70 seconds before imaging. And at this point, the contrast has reached the portal veins. Here's an example on the right. You can see the portal vein there. Contrast is opacifying it. And this is used for general abdominal pain. It's kind of a default option in patients who are coming in because it allows us to evaluate the solid organs in the bowel very well. In this case, we're also giving oral contrast. When giving enteric contrast, we have two options, barium and water-soluble contrast. Each has important uses. Specifically, barium is used in patients who could aspirate. The reason is because water-soluble contrast, when aspirated, can be harmful to the lungs. If we're suspecting perforation, we want to make sure we use water-soluble contrast. This is because barium can be harmful to the peritoneum if it leaks out of the bowel. Other applications are commonly involving water-soluble contrast. For example, if we're putting contrast in the bladder for a cystogram, putting it in the joint for an arthrogram, myelograms, HSGs, etc., you're going to use water-soluble contrast. Our next protocol is the CTA or CT angiogram. This includes a non-contrast phase and an early arterial phase. Here on the right, we see those two phases. This is non-contrast on top, and then the early arterial phase. And this is when the contrast best opacifies the abdominal aorta and the branch vessels. This is our best bet for evaluating for dissection, aneurysm, and hemorrhage. In the mesenteric ischemia protocol, we're evaluating in the early arterial and portal venous phases. This is because occlusions of the arteries and portal veins are common causes of mesenteric ischemia. On the top here, we have an example of the arterial phase where contrast has opacified the aorta. And in the superior mesenteric artery, we see a filling defect. That's an embolism, and that's the cause of mesenteric ischemia in this patient. On the bottom, we have a portal venous phase image in a different patient. Here is the portal vein, and we have a filling defect, looks fairly similar, and this is a clot, which was the cause of mesenteric ischemia in this patient. The enterography protocol is an early arterial phase. This is because the bowel mucosa enhances best at this time, so it's commonly used to evaluate for inflammatory bowel disease. We're also giving a unique type of oral contrast called volumen. It's a type of barium contrast that's very dilute. We're giving a high volume of it, so it distends the bowel and allows us to see the mucosa better. The GI bleeding protocol is fairly similar. We're giving the volume and contrast, but in this case, we're also including a non-contrast and portal venous phase. Reason is because if we see something on the arterial phase that looks like extravasation of contrast into the bowel, we can check on the non-contrast and portal venous phases to see if it was still there. For example, if we see it on the non-contrast phase as well, we know it wasn't contrast, extravasation, and instead it was probably something the patient ate. Here's an example of a GI bleed. This is a patient with Crohn's disease, and on the arterial phase, you can see that the bowel is nicely distended with this volume and contrast, low density, but we see this area of high density layering on top within one of the small bowel loops. And this was not present on the non-contrast phase, and so we know it's truly IV contrast that is extravasated into the bowel. Kidney stone protocol is essentially a non-contrast CT. We do not give oral contrast either. And the reason is because stones by themselves are bright, hyperdense, and so any contrast we give is just going to make it more difficult to see them. The kidney triple phase protocol is, as the name implies, 3 phases. We include the non-contrast to look for kidney stones. We also use nephrogenic and delayed phases. The reason is because nephrogenic phase is when the kidneys themselves enhance, and delayed phases is when the collecting systems enhance. That's when the kidneys have excreted the contrast into the ureters, and we can evaluate those best. Here's some examples on the right. We have the non-contrast CT, and this is the nephrogenic phase. You can see the kidneys enhance nicely. CT urogram is very similar. We're using 3 phases, but in this case, we're combining the nephrogenic and delayed phases and only scanning twice. The reason we do this is to save on radiation, because we're using this protocol in younger patients, often for hematuria, renal masses, or collecting system abnormalities such as a duplicated collecting system. Here's a diagram depicting the difference between the triphasic and urogram, because I think this can be confusing. The way that we do the triphasic is we give contrast, image in the nephrogenic phase, and then image in the delayed phase after waiting even longer. For the urogram, we use a split bolus technique, so we're actually giving contrast twice. We give contrast, wait, give contrast again, and then image once. And the reason is because the contrast given initially is going to be in the collecting system, and the contrast given at this time point is going to be enhancing the kidneys. So you can see both things in one scan. Other protocols we won't cover today will be the triphasic of the liver, pancreas, and adrenals. These are used often to evaluate for malignancies or other masses in these organs. The take-home points when thinking about abdominal CT protocoling is always think, do we need contrast? What type of contrast? And then what would be the best contrast timing?